again. Great to see you all. It's always fun when Nikki suggests topics to me, and she doesn't make it easy, which is good. I am going to share my screen and just make sure that you guys can see the giant slide that says risky. Great, thanks. So this is something that comes up quite a lot in practice, and I think it's a tension that you guys at Talk for Health will experience when you deal with kind of traditional mental health services that have a different focus for what they do, often to what you do. Well, shouldn't really, but sometimes there's a different focus which may be more immediate, and doctors deal with health problems of all kinds differently to other people. And so we're going to dig into a little bit today what doctors mean when they talk about risks and benefits in medicine, which you may have heard about, you should have heard about. I'm going to talk a little about risk assessment in psychiatry and what that looks like now. Talk a bit about the problems with prediction generally when we're talking about the types of risks we're interested in mental health services. And the problems with risk assessments, especially risk assessment tools that still are commonly used. And then think about like a collaborative way forward, where we've sort of digested all the things we've talked about, and there'll be some time for questions at the end. I hope we'll have time to talk. I'll go fast if we're running out of time. So first of all, content advisory, we will be talking about suicide and self-harm a little bit, although not in huge detail, to be aware of that. So risks and benefits. So you should have heard your doctors talk about risks and benefits. So all medical decisions are made based on weighing up the risks and benefits of giving a particular intervention or of not giving a particular intervention. So for instance, if you take paracetamol for a headache, you know that the risks of taking paracetamol are very, very small, vanishingly small, unless you've got liver damage or you have an allergy to paracetamol, and the benefits are fairly modest too. Your headache will be a little bit. Where in other cases, the risk benefit way up is much clearer. So if you have a life-threatening bacterial infection, take antibiotics, where the risks are pretty small generally, and the benefits are that you don't. So that's a pretty clear situation. So, but all decisions are made based on those. So doctors get pretty good at understanding like the statistics of what the risks of their treatments are, treating versus not treating. But there's another core principle in medicine which is often left out of decisions about risks and benefits. So doctors often talk in terms of making a decision for a patient, and less often talk about giving a patient information on risks and benefits to let them make the decision. And that's part of it's kind of wrapped up in the language of medical school and medical training, but we forget about that. And we forget about autonomy as a key principle in care as well. Patients should make decisions where possible about their own care, unless they're unable to for some reason. And risk, when we say risk, what we really mean, and there's lots of fancy definitions of risk, but what we really mean is what bad thing can happen. So when if somebody comes in with a particular problem, you think, well, what bad thing can happen because of this problem that they have, and what bad thing can happen because of the treatment that I'm giving, and how likely is that? And that is supposed to give you a sort of sense of whether or not you should take particular action, or what is likely to happen to this person with or without treatment. So that's the paracetamol. Psychiatry has a different focus to other specialties because there are very serious outcomes that do happen in people who attend mental health services. There are also outcomes in people who don't attend mental health services, but we tend to focus on them because they are related to distress, psychiatric conditions, and so on. So those are like suicide and violence particularly. And it's really important when it comes to violence, that users of mental health services are much more likely to be victims than perpetrators of violence. And so that's one of the things that we'll assess at risk of. Those people who have experienced mental health problems are likely to be vulnerable to exploitation and violence from other people. But occasionally, people with mental health problems do perpetrate violence as well, although it's rare. And psychiatry has sort of vacillated over the years when it comes to how they deal with the types of risks that a person poses to themselves or others. So on one end, there's this sort of libertarian view where you prioritize autonomy of citizens, where healthcare services or doctors have no responsibility for patients' actions, and where you would prevent suicide or other outcomes only by providing good care. And then at the other end of the spectrum is a more authoritarian and a paternalistic position where you have full responsibility in the event of negative outcomes, and you prevent suicide or violence by any means necessary, including deprivation of liberty. And each individual person will have a view about where they are on this spectrum or on these spectra. And you know, you might put yourself there or you might put yourself somewhere else. I think in the UK, we're more to the right than some other jurisdictions. We're more, we place more of a responsibility on healthcare services generally to prevent and reduce the risk of harm. And then there are cultural and legal pressures as well. So these are about violence. So there's been an increase in the years in media reporting of sort of sensationalistic tabloid media reporting about episodes of violence. And there are some well-known legal cases which have been sort of test cases for policy making in psychiatry generally and in medicine more broadly. There's a famous one, which is Tarasov, that led to the responsibility of a doctor to inform a person if their patient had threatened harm to that person. But we're going to focus less on sort of violence and whether perpetrator or victim risk assessment, and more on suicide and self-harm risk assessment, because it's a thing that's more likely to affect people who are attending services. So what is a risk assessment? So a risk assessment is any attempt to quantify the likelihood of an undesirable outcome via things like known statistics on the outcomes. So what types of people self-harm or attempt suicide or die by suicide. Triangulating that with the demographics of the patient, so what we know about this person. So I'm likely to be more concerned, for instance, about a male suicidal farmer who has a shotgun, who's recently been widowed, than I might be about another demographic group. So there's some sort of actuarial kind of risks that we know about different groups of people. And then there's a clinical interview and collateral with a carer or a loved one. And this happens particularly after an episode of self-harm or suicide attempt. And then there are risk assessment tools, which are kind of pro formas. We'll have a look at one later, that classifies people as low, medium, and high risk. There are a number of problems with that, which we'll have a look at later on. So an example, so this is the type of example that we test our medical students on. So psychiatry training is very preoccupied with risk assessment. So a lot of the time and emphasis and expertise of psychiatric training is focused on risk assessment. So if a person comes in, for instance, and they have harmed themselves or they have attempted suicide, you would do your clinical interview where you find out about the person and what's been going on for them. But you would pay particular attention to certain aspects of what had happened, so the event itself. So what was the method of self-harm? What were the precursors? So what led up to that? What was the person's mental state at the time? What's their mental state now? What are those persons' risk factors? So those might be things like age and gender. They might be things like occupation. Might be things like diagnostic groups, some diagnostic groups. And then you'd want to know their intent at the time. What did they want to happen? Because sometimes, I think as we talked about before, an episode of self-harm may be very clearly an attempt to die, but it can also be something else. It can also be an attempt to be free from pain. It can also be a communication. I mean, lots of different things. We'd ask them if they took precautions to prevent being discovered, and if they, wrote a will or did any of the final acts. So there's sorts of things that try and give you a sense of what actually happened, what was the intent behind it, what are the repercussions, and where are you now? So it sort of makes sense that when a person has harmed themselves and you want to help them, that you want to understand as much as possible. This is me in a few years. This picture of me taking a phone call from a colleague, because I get a lot of phone calls from other medical colleagues, for instance, about risk assessment situations. So perhaps it's an oncologist who has had a patient in their office, and they've given the person bad news, and the person has said that they don't know if they can go on any longer. And most medical specialists aren't trained to deal with a situation like that, or at least they perceive that they haven't been trained to deal with a situation like that. Because I think in reality, most people here, particularly if you've gone through the Talk for Health training, you would attend very closely to that person's distress and understand what was going on for them. Where if you're in an oncology clinic, particularly if you're very pressured for time and you don't feel comfortable exploring a person's distress and exploring their risk, then you phone a psychiatrist because you know that they are experts in assessing risk. And also they take on a lot of risks, so depending on the specialty you work in, you may see people who have had very serious suicide attempts in the past, or who have, if you work in forensic services, you may deal a lot with people who have been perpetrators of violence, for instance. So everything kind of, all the risk sort of flows upwards to mental health services generally, and doctors within mental health services, and psychiatrists particularly. And when systems take on responsibility like that, there are all sorts of unintended consequences, which we'll talk through, because I think no one is going to argue that exploring a person's distress and also their desire to end that distress, including thoughts of suicide or suicidal intent, no one would argue that that's not a really important part of being a doctor or a therapist or a peer supporter or a loved one. But when it becomes the responsibility of systems and services, there can be unintended consequences. And lots of doctors have been through suicide of patients and the aftermath. No professional wants their job to be reduced to decisions like who has to go into hospital and who has to go home. But often really stretched services, particularly services that work in emergency departments or acute care settings, because they're so stretched, their decisions do get reduced to those questions. And so that's what they're kind of preoccupied by. And the proxy measure for that is how risky is this situation. So instead of really being able to do a really long therapeutic assessment where you really get to know somebody, understand what's going on for them, understanding why they may be suicidal, for instance, what ends up happening is that you get kind of pressured into decision making about who goes into hospital and who goes home, at the expense of really meaningful clinical interaction. And so that becomes the focus of a lot of assessments, and some people here may have experienced that. Also, doctors who have been through a patient's suicide, quite apart from the obviously devastating consequences for that person's loved ones, it can be a serious investigation review in the hospital, can be a really devastating thing. And as I was talking to Nikki before the call, and a lot of people will say that they've been through coroner's court, that they've been through it, and while those investigations try not to be blaming, they often do end up inadvertently being blaming, and they assign responsibility or blame to the organization or to individual clinicians, which there are situations where that may be appropriate if there's been a dereliction of duty, but not always the case. And I think the process itself can be pretty traumatizing for people. So people end up getting, because of their training, which is very risk focused, and because of those experiences, they tend to be very kind of risk oriented and risk averse. And being too risk averse means that you can end up making bad decisions. So it brings us on to risk assessment tools. So risk assessment tools are kind of forms that are often deployed in assessment areas and in patient settings and psychiatric clinics, which attempt to stratify people into low risk, medium risk, or high risk of suicide or exploitation or violence. And despite there being very significant controversy over many, many years about the utility of these things, they are still used. So even in Oxford, where I worked up until recently, they were still being used in some departments. This is kind of what they look like. So you would tick where you think the person is, and often that gets added up into a score at the end, and the score assigns a person to, low, medium, or high risk, and decisions are made sometimes then on the basis of those scores. Because of the controversy and because increasingly clear evidence that these forms do no good and they can't predict things meaningfully, there's clear, nice guidance now that risk assessment tools should not be used to predict future behavior. They should not be used to determine who should and who should not be offered treatment or who should be discharged. And there's some other guidance here as well. Excuse me, I have a bit coughing. So really clear guidance that those tools shouldn't be used, but because NHS trusts and our practice here is very married to kind of bureaucracy and form filling and documentation in some cases. Well, documentation is always a good idea, but the other stuff can often kind of just distract from meaningful clinical care, but they are still used despite clear guidance that they shouldn't be used. And a big reason why they shouldn't be used is because prediction. Prediction, in the case of rare outcomes like suicide, it's not possible to accurately predict because it's a really complex human behavior that involves an enormous number of different factors. And because it's so rare, it means you get these kind of unusual and unexpected consequences. So for instance, most people who die by suicide will have been assessed as low risk. Because much more people are assessed as low risk than high risk, and suicide is rare, and it still happens in the low risk groups. Most people assessed as high risk will not die by suicide. In fact, the overwhelming majority, 90 to 97% of people assessed as high risk, but I think it's closer to 97%. Mental health patients are more likely to be victims of violence than perpetrators. This is another reason why prediction of violence risk is less useful. Most perpetrators of violence are not psychiatric patients, though there is a kind of a public perception, I think, of people who are patients under mental health services as being violent. And most mental health patients are women, whereas most completed suicides are by men, for instance. So risk prediction tools give you bad information, which predict wrongly the vast majority of the time, and lead to decisions made under duress, which may sort of panicked decisions, which may do the patient no harm, no good. So this is just a very nice summary of kind of risk and risk taking in mental health services generally. I'll read it out for you. Conceptualizations of risk are dominated by understanding patients as a danger to themselves or others. This perpetuates a view that risk is something to be avoided and minimized. Mental health professionals are therefore positioned as responsible for identifying, quantifying, and containing risk. This aspect of the professional role has been seen to be a mechanism of control, potentially threatening the therapeutic focus and acting as a barrier to recovery-oriented relationships with patients. So if we're more concerned with the idea that our role is to prevent any kind of harm, and that we can predict that harm, and that we should prevent people from taking any kind of risks or going through anything that that we perceive may modify that risk. What we end up doing is we end up sort of forgetting about the autonomy side of things and the collaboration side of things. And I think the idea that we should get rid of all kinds of risks is a little bit related to the idea when we talked last time about trigger warnings. It's a little bit like the idea that all risk should be avoided in all situations. Is a little bit like the idea that any kind of difficult or negative experience should be avoided at all situations. And of course, both of those things will ultimately end up perpetuating risk and perpetuating difficult and negative experiences rather than reducing the risk. So that's a kind of a progressive kind of medical view. From a service user's point of view, from a patient. So this is a really nice blog by a woman called Emma, who was a patient for many, many years in mental health services. And she says, if professionals simply risk assess without acknowledging pain and suffering, then people learn that their pain and suffering do not matter. They only receive care and validation in relation to the gravity of their risk of self-harm, suicide, or harm to others. This can become a cycle of invalidation that increases risk behaviors, which professionals then have to further assess, contain, and regulate. So this reminds me a little bit of some of the things I saw very early on in my career, when people who self-harmed frequently would come into the emergency department, and emergency department staff didn't really have any training in managing how to deal with that, and they would become overwhelmed and frustrated with people who would repeatedly come in. And one of the things that sometimes happens is that they will respond in a punitive way to that kind of behavior, which of course makes people more shamed and feeds into a cycle of poor mental health, which increases the risk of self-harm. So these kind of things, like when a doctor's training becomes overly focused on risk assessment, and so their skills in responding to dealing with distress atrophy, and the system's ability similarly to respond to distress atrophies. What ends up happening is these self-perpetuating cycles of responses. And if we only think in terms of short-term risks, what we end up doing is forgetting about more long-term benefits. If we think that, well, my focus in this consultation must be to assess the risk, predict the risk, and then reduce the immediate likelihood of the risk, we forget that really genuinely sitting with a person's distress and understanding what's going on, and understanding, I suppose, their story and where the experiences or feelings that they're having has come from, will ultimately lead to not only more likely to lead to lower short-term risk, but long-term benefits as well, as a kind of a virtuous cycle. So the problems with the way risk assessment is currently used is that the first is that we know that it's not possible to accurately predict rare events. Now, it doesn't mean that we shouldn't explore and try and mitigate really obvious kind of imminent risk to people, but it does mean that we shouldn't overestimate our ability to predict things. The focus on risk may interfere with the therapeutic relationship and disempower patients, as we've seen. And defensive practice, so kind of practicing in order to prevent, in order to kind of protect yourself as a clinician, or in order to absolutely prevent any likelihood of short-term risk, leads to poor decision making. Risk assessments typically aren't user-centered, so most patients don't even know they've been risk assessments. Less than half of people, when we do surveys, have any idea that they've had a risk assessment done. And it has an unequal application to mental health patients, for instance. So doctors don't risk assess. If somebody comes into the emergency department and they've just been in a drunken brawl and they've assaulted somebody and they've been assaulted, we don't risk assess those people, but clearly that person is at a high risk of violence the next time they're intoxicated. And we don't risk people who come in, for instance, with drug overdoses who don't see psychiatric services. So there's a sort of a inequitable application of risk to mental health patients, because those are people who are seen by psychiatry, and that has become such a focus of psychiatric assessment. The other thing is there are different ideas of risk as we've seen. So doctors tend to think, well, psychiatrists and mental health services and organizations tend to think in terms of suicide particularly. But patients see different risks. So risks of not being able to go back to work, risks of not being able to have a relationship, and so on. And so incorporating patients' ideas of bad things that could happen, which is what risk means, is really important and generally isn't done. And in stretched services, the language of risk is sometimes the only thing that is heard. So in services where the decision-making gets reduced to who should be admitted and who shouldn't be admitted because of time pressures, then sometimes people learn that the only way that they can effectively communicate their distress in a way that it gets listened to is to communicate using the language of risk, the language of suicide. And that means that, you know, the real kind of context and the real content of the problems they're having doesn't get communicated, and it ended up being just admit or don't admit. And so doctors and patients ends up being at odds with each other, different goals, because there isn't a collaboration. And if we think for a second about what actually prevents suicide, well, in complex behaviors like suicide, which, you know, statistically are rare, 10 per 100,000 people in the UK. What does tend to work is population-based approaches, so approaches that affect the whole population. So, for instance, people who are as old as me will know that about 15 years ago, the size of paracetamol packets became much smaller. You can only get 6 or 8 now in a packet, and that's had a measurable impact on reducing suicidal population. Similarly, netting on bridges or high buildings has a measurable impact on the rate of completed suicide. And so instead of training and forcing doctors and organizations to be wholly focused on risk assessment and risk reduction, if we instead had services that were for the whole population, that were patient-centered, equitable, so you know, accessible to everybody, and that were high quality, then that's the sort of intervention that on something like suicide is likely to have more effect than this kind of focus on making bad decisions under duress. So just a couple of take-home things. So when I talk to doctors and mental health services about risk assessment, these are the things that I say to them. So risk assessment tools don't work. They take up valuable clinical interaction time. Don't use them. That's time that could be spent, you know, relationship forming, doing therapeutic assessment, and figuring out with a person what we should do next. Assessment of harms and risks is obviously unavoidable sometimes. You know, part of dealing with really difficult and distressing experiences and you know, serious psychiatric illness sometimes means that you do have to explore those things. But risk assessment should be part of clinical assessment and formulation. You know, where the assessment indicates that it's necessary, and it should be a collaboration between a clinician and a patient. Where possible, there are cases where a person is too unwell to collaborate in that kind of decision making, and there are cases where people we do need to invoke the Mental Health Act, for instance, if the person is for instance, very psychotic. But planning and risk assessment should be a collaboration, and it should be an open dialogue, whereas at the moment it's sort of done a little covertly. As well as assessing risks, we should be much more focused on strengths and capabilities. So instead of being overly focused on what bad thing can happen, we should also be focused on, you know, what strengths and capabilities and resources and support network can we activate as well. And certainly when, you know, I inevitably am involved in risk assessment frequently, and that's what the conversation comes about. What can we do together to mitigate the risk of how awful you're feeling right now? So skills in high quality assessment and care embedded in effective and safe services should be prioritized. Risk assessment is a part of that, but it's quite a small part of that. Actually, the other stuff is much more important. And as I said, when you are overly focused in your training and your design of services and risk assessment, that other stuff atrophies. And positive risk taking, which means saying, look, yes, the risk of doing this is potentially high. So the risk of a person, say, going home that may make you feel uncomfortable, but it may provide more autonomy. It may put the person in a position where they are more likely to recover rather than less likely to recover. So positive risk taking as an idea sort of caught hold and may result in better decisions generally in most cases. So those are just some ideas on kind of risk and risk taking and benefits versus harms and how we do things here compared to how we do things in other jurisdictions. And I'll stop sharing